Why visual fields matter, from silent loss to real-world function. A person can read the smallest line on an eye chart and still have a serious problem with peripheral vision. This is especially common in glaucoma, where vision loss often begins slowly at the sides of the visual field, while sharp central vision remains clear. That is why visual field testing matters. It measures not only how clearly a person sees, but also where vision is missing, how sensitive each area is, and whether the pattern is changing over time. In many patients, the test detects functional loss long before they recognize a problem in daily life. What a visual field test measures. A standard eye chart measures central visual acuity, the ability to see small letters or details directly in front of you. A visual field test measures the wider area that can be seen while the eyes remain fixed on one point. During standard automated perimetry, one eye is tested at a time. The patient looks at a central target and presses a button whenever a flash of light is seen. The machine presents lights of different brightness at many locations and estimates the dimmest light visible at each point. The result is a map of visual sensitivity across the field. A report may include a grayscale map, which gives a visual impression of missing or reduced areas, a total deviation map, comparing the result with people of the same age, a pattern deviation map, which helps identify localized defects despite generalized blur from conditions such as cataract or a small pupil. Mean deviation, an age-adjusted summary of overall field loss. More negative values generally indicate more loss. Visual field index, a percentage estimate of remaining age-adjusted field function, with greater emphasis on points near central vision. Pattern standard deviation, which highlights localized, irregular defects. These numbers are useful, but they should not be interpreted alone. The pattern, location, reliability, structural examination of the optic nerve, and the results from previous visits are all important. Why patients often do not notice visual field loss. Loss usually begins outside the center. In chronic open-angle glaucoma, damage is usually gradual and often begins in the peripheral field. Early disease may produce small blind spots or areas of reduced sensitivity that do not interfere with ordinary tasks. The National Eye Institute notes that early glaucoma often has no symptoms, and many people do not notice that their side vision is changing until the disease is more advanced. This creates a dangerous mismatch. The optic nerve may already be losing function. The eye chart may still show good central vision. The patient may still feel that vision is normal. A visual field test may reveal the problem before everyday symptoms become obvious. The two eyes can compensate for each other. Most people do not routinely compare one eye with the other. If a defect affects one eye more than the other, the better eye may help cover the missing area. When the visual fields from both eyes are combined, some defects may be less noticeable than they are during one eye at a time testing. Research has shown that a person may have measurable defects in each eye, while the combined binocular field appears relatively preserved. This is one reason that both monocular results and the likely binocular effect must be considered. The brain adapts to slowly changing vision. A slowly developing blind spot does not produce the same sudden warning as a new loss of vision. Patients may unconsciously turn the head more, scan the environment more often, walk more cautiously, or rely on familiar surroundings. These adjustments can hide the problem until the remaining field becomes much smaller. Adaptation is helpful, but it can also create false reassurance. A person may function adequately in a familiar home while struggling in a crowded store, on an unfamiliar street, in dim lighting, or behind the wheel. How field defects affect daily activities. The effect of visual field loss depends on where the defect is located, whether it affects one or both eyes, how severe it is, and how quickly it developed. No single field score predicts every real-world ability. For the full table, please open this article on visualfieldtest.com. The relationship is not always predictable. Studies comparing central and far peripheral loss have found that central damage is more closely associated with several measures of quality of life and daily activity, while far peripheral damage may be especially important for stride length, gait variability, and hazard detection. Driving. Driving requires more than reading road signs. It requires detecting vehicles, pedestrians, cyclists, and objects approaching from the side. maintaining lane position, responding quickly to unexpected hazards, searching mirrors and intersections, managing glare and low light conditions, dividing attention between several parts of the visual environment. Moderate or severe visual field loss, particularly when it affects both eyes, has been associated with slower responses to road hazards, poorer lane maintenance, greater difficulty driving at night, increased self-restriction, and a greater likelihood of stopping driving. Recent review evidence also links more severe bilateral field loss with poorer driving performance and a higher risk of motor vehicle collisions. A visual field test is important for counseling, but it is not the same as a driving test. Safe driving also depends on visual acuity, contrast sensitivity, attention, reaction time, cognition, neck movement, medications, and experience. Driver licensing standards are jurisdiction-specific, so patients should check their state requirements and ask about a formal driving evaluation when appropriate. State agencies may impose different restrictions or medical review requirements for people with reduced vision. Walking, mobility, and falls. Peripheral vision helps a person notice objects approaching from the side. Central vision helps identify steps, uneven surfaces, and details in the walking path. Losing either part of the field can cause a person to slow down, shorten steps, widen the base of support, or become more cautious. Research in glaucoma has linked visual field loss with greater fear of falling, shorter steps and strides, greater variation from one step to the next, fewer daily steps, difficulty with instrumental activities such as shopping and navigating unfamiliar places, increased mobility restriction. Faster rates of binocular visual field loss have also been associated with a greater history of falls, even after considering the existing severity of the field defect. This is why a patient who says, "I can still see," should also be asked, "Have you stumbled recently? Do you avoid stairs or uneven ground? Do you bump into objects? Do you feel unsafe crossing a street? Have you reduced outdoor activities? Do you need brighter lighting at home?" Reading. Reading depends on clear central vision, but it also depends on the ability to process several letters at once and move smoothly from one line to the next. Defects near fixation or in the central visual field can reduce the visual span, the amount of text recognized during one glance. People with bilateral glaucoma may read more slowly, lose their place, skip lines, struggle with small or low contrast print, and become tired during prolonged reading. These problems may occur even when visual acuity remains relatively good. In one study, glaucoma was associated with slower oral and silent reading, and sustained silent reading was particularly affected. Reading difficulty is therefore not always corrected by stronger glasses. Helpful strategies may include better lighting, larger print, higher contrast, magnification, electronic reading devices, and vision rehabilitation. Visual fields and quality of life. Clinical measurements and patient experience are related, but they are not identical. Two people with similar visual field scores may have very different lifestyles, work demands, home environments, coping strategies, and levels of disability. Patient-reported measures. Several questionnaires help measure the effect of visual loss on daily life. The Glaucoma Quality of Life 15 questionnaire focuses on central and near vision, peripheral vision, glare and dark adaptation, and outdoor mobility. The National Eye Institute Visual Function Questionnaire 25 covers areas such as general vision, near and distance activities, driving, social functioning, role difficulties, dependence, and mental health. General disability and activity questionnaires may assess walking, shopping, reading, household activities, and independence. Studies consistently show that quality of life tends to worsen as binocular visual field loss becomes more severe. Faster visual field decline is also associated with worse later vision-related quality of life, even when two patients have similar amounts of damage at a single visit. Objective functional measures. Research can also measure function directly using reading speed, number of daily steps, walking speed, and stride variability, simulated shopping or object-finding tasks, falls, driving restriction or driving cessation, performance of instrumental activities of daily living. These measures are valuable because patients may adapt to loss or may not recognize which visual problem is causing a particular difficulty. Conversely, a patient may report glare, poor dark adaptation, or fatigue that is not fully explained by a routine field score. Clinical testing and patient discussion should therefore be used together. How visual field results influence treatment. Establishing functional damage. In glaucoma, diagnosis usually combines the appearance of the optic nerve, intraocular pressure, the drainage angle, retinal nerve fiber and ganglion cell measurements. Visual field results. The pattern and consistency of change over time. A visual field defect that matches the appearance of the optic nerve provides evidence that structural damage is affecting function. Characteristic glaucoma patterns include a nasal step, arcuate defect, or localized loss that respects the horizontal midline. Confirming progression. Treatment decisions should not usually be based on one questionable field. Clinicians ask, was the test reliable? Is the defect in a pattern consistent with the disease? Does it match the optic nerve or optical imaging? Has the same area worsened on later tests? Is the rate of change fast enough to threaten useful vision during the patient's lifetime? Is the intraocular pressure appropriate for the amount of damage? If progression is confirmed, the treatment target may need to become more demanding. Importantly, glaucoma can continue to progress even when the measured intraocular pressure appears to be within a statistically normal range. For this reason, pressure readings alone are not enough to judge whether treatment is working. Treatment escalation. Depending on the disease and the patient's circumstances, confirmed or concerning progression may lead to improving eye drop technique and adherence, changing or adding pressure-lowering medicine, lowering the target intraocular pressure, selective laser trabeculoplasty or another laser procedure. Closer follow-up, glaucoma surgery. The purpose of these treatments is to prevent or slow additional loss, not to restore visual field that has already disappeared. Early treatment is especially important because established glaucomatous field loss is generally irreversible. When surgery may be considered, visual field results help determine how much vision remains to protect and how much risk the patient faces if loss continues. Surgery may enter the discussion when the target pressure cannot be reached with tolerated medicines and laser treatment. The field or optic nerve continues to worsen despite apparently acceptable pressure. The disease is advanced or progressing rapidly. The remaining field is already threatening independence, mobility, or driving. The patient's age and expected lifetime make further loss especially consequential. There is no universal visual field number that automatically means surgery is required. A person with early, slowly changing disease may reasonably choose a different approach from someone with advanced loss, rapid progression, a strong family history, or only one reliably functioning eye. Guidelines emphasize adjusting the target pressure according to disease stage, measured rate of progression, life expectancy, and quality of life risk. Visual fields in disability assessments. A visual field defect can cause meaningful disability even when central visual acuity is good. This is important because many general surveys and screening systems define vision loss mainly by visual acuity and may not capture impairment caused only by field loss or poor contrast sensitivity. Social Security disability and statutory blindness. In the United States, the Social Security Administration recognizes visual field loss as a distinct form of visual impairment. Its adult criteria include contraction of the visual field in the better eye and loss of visual efficiency. Under the Social Security definition of statutory blindness, a visual field limitation in the better eye may qualify when the widest diameter is 20 degrees or less. Social Security may require automated static threshold perimetry, manual kinetic perimetry, or specific measurements of the better eye, depending on the listing being considered. Screening tests such as a simple confrontation field are not sufficient to establish a listing. Meeting a listed visual field threshold is not the only way a person may qualify for disability benefits. If the formal criteria are not met, the Social Security Administration may still consider how the visual disorder affects the person's ability to function and work. Detailed medical records and descriptions of real-world limitations are important. Disability under the Americans with Disabilities Act. The Americans with Disabilities Act includes seeing, walking, reading, and working among major life activities. However, protection under this law is not the same as Social Security disability benefits or the legal definition of blindness. Eligibility depends on how substantially the impairment limits major life activities in the relevant circumstances. A disability assessment may therefore need more than a diagnosis. It may require the visual field printouts, the better eye and binocular findings, the date and reliability of each test, the cause of the defect, treatment history, work and mobility limitations, difficulty with driving, reading, stairs, or navigating unfamiliar environments. Why repeated testing is essential. The first test may not represent the true baseline. Visual field testing is demanding. The patient must maintain fixation, respond consistently, distinguish real flashes from absent flashes, and stay attentive for several minutes. People often improve after they understand the task. A learning effect may make the first test appear worse or less reliable than later tests. Studies have found shorter test times, fewer errors, and improved sensitivity on repeat testing, particularly in patients with little previous perimetry experience. Results vary from day to day. A visual field may be affected by fatigue or poor concentration, anxiety or misunderstanding the instructions, dry eye discomfort, blurred or incorrect optical correction, cataract or a small pupil, eyelid or lens rim obstruction, technician experience, time of day, false positive or false negative responses. Some variation is expected even when the disease is stable. Test-retest variability is often greater in damaged areas, especially when sensitivity is already low. Trend analysis separates change from noise. Clinicians use a series of tests rather than comparing only the latest result with the first one. They may examine whether the same locations repeatedly worsen, whether the overall mean deviation is declining, the estimated rate of loss per year, whether the change is consistent with the optic nerve and optical imaging, whether the defect persists after confirmation. A single abnormal result may be a warning, but persistent change on repeat testing is more persuasive. Research on progression analysis emphasizes confirmation, attention to the pattern of loss, and integration with structural findings. Testing frequency affects how quickly progression is found. Testing more often can identify rapid progression sooner, although excessive testing can increase patient burden. Evidence suggests that obtaining more than one reliable baseline test and repeating fields at regular intervals early after diagnosis can improve the chance of detecting meaningful change. The European Glaucoma Society recommends particularly close visual field monitoring during the first years after diagnosis, with later adjustment according to risk and stability. When a field defect has already been identified, using the same measurement strategy at later visits makes comparisons more reliable. This principle is also reflected in National Institute for Health and Care Excellence guidance. How patients can make visual field testing more useful. Before a test, patients should tell the technician if they are tired, uncomfortable, or having trouble seeing the fixation target. Use the prescribed near correction or trial lens provided for the test. Keep looking at the central target rather than searching for flashes. Press the button when a flash is seen, but avoid guessing. Blink normally and report significant dryness. Ask whether the test was reliable and whether it should be repeated. Bring up changes in reading, mobility, night driving, glare, or falls even if the test appears stable. Patients can also ask, which part of my field is affected? Is the defect in one eye or both? Does it affect central vision, peripheral vision, or both? Is the change confirmed? What is my rate of visual field loss? Is my treatment target still appropriate? Does the result affect driving, work, or disability paperwork? Would vision rehabilitation, occupational therapy, or a driving assessment help? Conclusion: visual field testing turns a vague concern, something may be changing with my vision, into a measurable picture of function. It can reveal silent loss before a patient notices missing objects, guide treatment escalation before additional vision is lost, help determine when laser or surgery should be discussed, and document limitations relevant to driving, work, disability, and quality of life. The most meaningful interpretation does not come from one number or one grayscale image. It comes from reliable repeated tests, the location and pattern of loss, the condition of both eyes, the rate of change, and the patient's actual experience in daily life. Protecting vision means protecting not only the ability to read an eye chart, but also the ability to move safely, read comfortably, drive responsibly, and remain independent. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.